So why study dysmorphic features? Through the last 5 sessions of this group of meetings, what we have seen are excellent MRI images, EEG recordings that are very specific to disorders, and a whole lot of other investigative modalities. But if you look at the face of a human being, I think it's the easiest thing to see because you don't even have to order an investigation. And occasionally you may be even lucky enough to make a diagnosis. For example, any of us in the audience that have seen a child with Down syndrome would find it extremely easy to make a diagnosis of Downs by vision alone. And sometimes when you've got experience, then you can make other such diagnoses by seeing. And I think it's very important to do that because many times it minimizes and even occasionally makes us make specific diagnosis. And this shortened list helps us to have a small number of investigations that may be very specific towards the diagnosis, especially in a country where I think investigations are paid for by patients, and it becomes extremely difficult for them to have a battery of tests when you're guessing what the diagnosis may be. Also, it allows for us to follow the family. So if you have family photographs or other members that are affected and you get to see those other members in photographs, and I'll show you an illustration as I'm giving my talk, and also the parents. So it's very often that when you look at parents, you can make out if some of them may have similar or identical features, which may help make a family diagnosis. But most of all, I think that it is extremely interesting and it's for free that you can look at people's faces. So it's very important. So the outline of my talk is very, very simple. I'm just going to give a few examples starting from the top of the head. That's the hair, eye, nose, mouth, teeth, ear, and then just talk about how we approach a dysmorphic child. So starting from the beginning, these were 2 unrelated children who had been referred at a young age, loosely labeled as oculocutaneous albinism. Now, all of us who see oculocutaneous albinism know that basically this is decreased formation of melanin pigment, and therefore all tissues, whether it is the skin, hair, or the eyes, they are hypopigmented. What we see in these children is that the eyes are colored normally for an Asian child, but you can see that the hair on different parts of the face is hypopigmented. This is when you get thinking about what is really happening. And when you look much more closely and you're seeing different parts of the body, whether it's the top of the scalp or the eyebrows, eyelashes, or even the body hair. And what you can see is that the hair is actually silvery gray in color. And this would make you think of something that shows pigment dilution rather than absence of pigment, that is melanin. And this is a group of disorders which you can diagnose by examining the hair. So on the right side is a normal hair shaft looked under a microscope without any stains. And you can see uniform pigmentation of hair. The melanin is spread uniformly. Whereas on the left side, you see clumping of the melanin pigment because the transport of melanin through the melanosomes is faulty in this group of conditions. So this is Griscelli syndrome, and it's a rare disorder which has got several subtypes. And all of them are inherited in an autosomal recessive pattern, but very easy to diagnose if you've got a microscope where you can place a hair from the patient under a microscope to look at. So mainly it's a melanin transport disorder. It gives rise to silver gray hair on the scalp and body. And wherever the pigment transport has been arrested, you see this clumping of melanin, and it's easiest to see it in the hair of a patient. You can evaluate hair under light microscopy. On the right side is something that we did just at the side. It didn't require any sort of expert thing. You just put a cover slip on a hair with a little bit of water and look under 10 or 40 microscopy, and you can see the hair with the clumping or irregular pigmentation. In all 3 types that are known, that's Griscelli syndrome type 1, 2, and 3, you get the same sort of clumping of pigment. But each subtype is caused by 3 different genes, of which the MYO5 gene is the one that presents with a neurological phenotype, and quite a severe phenotype at that. So they have severe neurological symptoms, which are noticeable right from the beginning, from birth, and can manifest as hypotonia, absence of coordinated voluntary movements, epilepsy, and severe psychomotor delay. This stays pretty static as the child grows up, and the pigmentary abnormalities give us a clue onto what the diagnosis may be. They're quite difficult to treat and require multiple anticonvulsants to get the seizures under control. And this probably doesn't do very well on the long term. But the subtype that is caused by another gene, the RAP7, presents many times as an HLH-like picture. So you have a hematological and an immunological phenotype, which actually, if recognized early with the same sort of mechanism, is amenable to bone marrow transplant and seem to do well once they are transplanted. The third type, that is the gene which is located on 2q37, is the MLPH gene called melanophilin. And this particular subtype has only the skin and hair manifestations with no other body problems. So I think it's extremely important for us to know that just by looking at the hair of an individual under a microscope, or even guessing it from the appearance of the individual, you could make a difficult diagnosis of a rare recessive condition. Of course, you need genetic testing when you're offering prenatal diagnosis, because there's a recurrence of 1 in 4 in each pregnancy. You may sometimes get confused with other conditions which could present with an identical phenotype, especially if they've been untreated. So phenylketonuria, which is an amino acidopathy, which is one of the commonest amino acidopathies seen worldwide. Untreated because it follows the same pathway as melanin synthesis and can also give rise to hypopigmented hair with normal colored eyes. But here, the neurological phenotype is very different, and you can have a different pattern of seizures, and again, recognized early, especially if we have newborn screening in place, you can get them to get treated. I would like to highlight that we've got now in India, indigenously produced food, which is cheaper than what we can import from outside, and it seems to be working effectively. And now that these children are living much longer and without neurological handicap, being appropriately treated, we have also started now producing flour and biscuits and things that they can take to school once they are reaching school age. So I think there's a lot of hope when you look at the external appearance of the hair and make the right sort of diagnosis. So this is about metabolic issues that may come from hair. Now, I'll give you a case scenario which we found initially very difficult. This was a 17-year-old girl who had come, and she had been to several clinics before she met us. She was born to consanguineous parents. She had had an older brother who had died at the age of 16 years, and we didn't have many details from her. As you can see in her face, she just had a divergent strabismus. And she had a history of movement disorders, which was long-standing and progressive, and they came from a low socioeconomic family with not many medical reports available to them. So this, in the past history, she had had pulmonary tuberculosis that had been treated for a duration of 1 year, and she seemed to be generally poorly built and had a history of recurrent respiratory infections. But when you look closely at her, what she had was very obvious signs of what we know as ataxia telangiectasia. So her eyes had the classic telangiectasia, and the right-hand picture at the top shows you the little picture that we had from the brother who had a similar phenotype from one family picture that had been produced. So he obviously had the same condition. We know the CNS manifestations show progressive cerebellar atrophy, and she had early signs of bronchiectasis, which are all in keeping with this condition. So not difficult to diagnose if you're sitting and thinking about the condition. And this is easy enough to see, but sometimes you think that the eye manifestations may be something more acute, and unless you're asking specifically, you might overlook these easy manifestations. So what do we know about ATM, the gene that causes ataxia telangiectasia? There are several manifestations that it can present as. The majority present as classic ataxia with between 1 and 4 years of age, and they have progressive movement disorders in the form of chorioathetosis. They also have an associated immunodeficiency, and there's a heightened risk of hematological malignancies. The non-classic ones are the ones which are adult onset or those with dystonia as the primary symptom. Now we know that this gene is important for maintaining double-stranded DNA in intact position, and the DNA repair mechanism is overseen by this gene. It acts both within the nucleus and in the cytoplasm of the cell. And any alteration in its by mutations leads to a predisposition to lymphomas and leukemias, which are exceedingly common. And these malignancies, especially if they're treated with ionizing radiation, can get worse. So we have to be careful. Even investigative radiology can sometimes be harmful to the patient. So occasionally, for people that do cytogenetic studies, so even in the blood chromosome makeup, you occasionally get this 7-14 translocation, a normal chromosome 7, a normal chromosome 14, and when they're stuck end on end and have a 7-14 translocation, this is sometimes seen as a poor prognostic factor in ataxia telangiectasia because immunodeficiency is heightened when this happens. But what's coming out in the recent literature not only applies to the patient, it also applies to the female carriers of the gene who have only one copy of the gene, have no manifestations of ataxia telangiectasia, and may be a parent of a child. Female carriers have a 5-fold increased risk above the population risk of developing breast cancer. And the most recent literature shows that this risk increases to about 33% by the age of 80 years. So quite a significant risk of developing breast cancer. Male carriers can develop colorectal cancer, but in a little reduced form. So regular screening of parents who are carriers is advised. And it's very important that we look at their health also and follow the family history to see if there are other carriers in this recessive disorder within the family. So from a single dysmorphic disorder, it's possible to actually look out to another morbidity, which might have significant inputs for the family. Now, this is something that we saw quite a lot of in our pediatric clinics, and I'm very fond of this syndrome. If you just happen to see this child walking on the road, you'd probably not ever think of her as being dysmorphic. So this 10-year-old child who presented with moderate intellectual disability and quite a significant speech delay of the expressive speech, especially, had been operated for tetralogy of Fallot as a young child and was noted to have neonatal seizures. We didn't have many records from that time. But looking closely at the child, you see certain subtle features. One of them is that the ala nasi, the two ends of the nose, are much smaller. And if you look at her side profile, she's got an overfolded ear. The top of the ear is folded. And then you've got a slightly sloping chin. So she's got micrognathia. Very little else was seen, but this combination of having tetralogy of Fallot or other conotruncal heart defects to most geneticists would point out to be a chromosome 22q microdeletion. It's otherwise known as velocardiofacial syndrome or DiGeorge syndrome. And it's quite easy to pick up on a regular FISH test if you're suspecting it, or if you haven't suspected it, then you can do an array which will pick up copy number variants. And you can see the standard deletion, which spans about 3 MB in size and has about 50 genes in the segment that is deleted. So it's pretty easy to pick up. The red signal indicates the area of interest. And when you have 2 copies of chromosome 22 indicated by the 2 green signals and you've got 1 copy missing, you know that the patient has got a 22q microdeletion. Now, the big thing is that in majority of our centers, we have got FISH, and this cannot be picked up on routine karyotype. So you need to suspect it clinically, especially because the range of features that there are at least 180 different clinical features that have been associated with velocardiofacial syndrome. And at least 90% of people who have 22q microdeletion will have facial dysmorphism. So I'm just going to show you what are the features that we use as clinical diagnosis. If you look at the eyes, most of us have a crease above, which is called the superior orbital crease. And if a person with 22q is looking at you straight on, the superior crease is not very visible. So this causes the impression of hooded eyes. When you look at the nose, the entire segment, lower segment of the nose, the 2 ala nasi and the central segment which forms the tip of the nose, comprise 1/3 each to form a full nasal segment. If you look at somebody that's affected with 22q, and this is pretty consistent for Asian population especially, you find that the alae nasi are much smaller on both sides, and therefore the central part of the nose looks really bulbous, and this is what is described as the bulbous nose. And when you come down to the mouth is small. So how do we define a small mouth? You draw a straight line from the edge of the nose downwards, and most of us would have our mouth extending beyond this line on both sides. But if you draw a similar line for somebody that has velocardiofacial syndrome, the mouth comes within this group. In addition to that, some of them have small ears, and the majority of them in both their primary and secondary dentition have extensive caries, but the face is pretty recognizable. And these are several patients that we have had at all age groups from different ethnicities. And what's common to all of them is that they have hooded eyes. You can't see the superior orbital crease. All of them have small alae nasi, this lady especially. And they have small mouths which would fit into the line that you would draw on both sides. And I'm sure after this session, you will have no problems identifying the dysmorphology of 22q, because it's actually easy to do once you have trained your eyes to see the right features in a person. And you will agree with me that many of them look similar when you look at them. So it's not just the Indian population. These are papers from different faces from different ethnicities. And you'll see that whether it comes from the Caucasian population or it comes from the Far East, the face similarities stay constant with the hooded eyes, the small mouth, and the very small alae nasi. What's a little difficult in the African population is the shape of the nose, but even so the mouth remains much smaller and the face has got the same longish profile. So it is not difficult if you train your eyes to see, and it's pretty population pan-ethnic when you look at the face profile of this particular condition. Now, when you see very young children with this condition, and this is something that we have worked through for a long time, to look at their faces, it's the nose that gives it away. And this part of it was what I wanted to show, that when a child cries, the mid part of the nose looks much wider, almost like a little diamond that is drawn in the middle of the nose. And this central widening of the nose is what gives away the face. In addition, if you have the conotruncal heart anomaly, then that will give you another clue, or if they have palatal problems. But the central broadening of the nose, and especially when the child is crying, I'm sure you'll agree, is an easy thing to find out if you're looking at them, and easy to look and at least think about if you're trying to diagnose 22q in a younger child. There's a lot of implications on how we progress with these children. If they are going to have cardiac repair, in view of the immune deficiencies, you have to be careful to see the type of blood that these patients get, and most of them are given irradiated blood. 90% and above have got developmental delay. A lot of them have got expressive speech delay, and a lot of them have got nasal speech. And this is caused by the velopharyngeal insufficiency. Most times when an ENT person is looking at their throats and they find adenoid hypertrophy, they suggest removal of the adenoids or adenotonsillectomy. But this actually causes worsening of the nasal insufficiency in patients who have got the condition. So you have to be careful. The hypocalcemic seizures that are seen usually in the younger age group are caused by the primary hypoparathyroidism, which is part of the syndrome. And this hypocalcemia can recur whenever there is a situation of stress like surgery. As they grow up, they're often diagnosed as having autism spectrum disorder with or without ADHD. And the main issues that you focus on are the social cognitive defects. Early onset psychiatric illness is a very, very key thing. Now, I would like to say that this is something that we have been learning about in the last 15 years or so, that psychiatric illnesses such as schizophrenia are seen in about 1 in 3 patients who have got 22q microdeletion. And considering that it's the commonest microdeletion syndrome worldwide, 1 in 3,000 to 6,000 patients have it. This is an amazingly common thing. So if you look at the statistics, 30% of 22q patients develop schizophrenia, usually in their 2nd or 3rd decade. Conversely, if you had to test all patients with severe schizophrenia, 1% of them would have 22q microdeletion, making it a monogenic cause for schizophrenia, which is very rare to find. And emerging literature shows that medicines such as clozapine are more effective in treating these because of the schizoaffective disorders that they have. And there's a lot of emerging literature about the psychiatric complications that develop in this particular condition. So it's got a lifelong impact on the health of the patient. Now, coming to the mouth, this was a child, a male child, who had been, this is actually my colleague, Dr. Ashka's family that she presented to us recently. This was a child who presented with severe developmental delay, and he had absent speech. This was his appearance. And in the family history, there were 2 other male cousins who were also affected. And if you look at the pedigree, the abbreviated pedigree shows that these male affected individuals were linked through female relatives that were otherwise unaffected. What's significant in them is this big, wide mouth that the child had with slightly widely spaced teeth. And the photographs of the 2 cousins that we got subsequently also show quite significant mouth size. And this would make us think of a condition called alpha thalassemia mental retardation syndrome, ATRX for short, a rare condition, but recognizable. And these are pictures from the literature. And you'll agree with me, all of them have this wide mouth, which is the characteristic part of this face, sometimes totally exaggerated. Now, these children have alpha thalassemia, which can manifest in the peripheral smear as having Heinz bodies, which are denatured hemoglobin in the red cells, and which can look like a little pinched outgrowth also in some cells. But that's seen in about 10% of children. They have severe psychomotor impairments, urogenital abnormalities seen in certain specific mutations, and this characteristic facial dysmorphism. So the mouth is the key thing. And what's being found out more recently is that the ATRX gene has a tumorigenesis potential and is involved in brainstem gliomas. And these gliomas have specific therapy when they are caused by ATRX. What is not really clear just now is whether patients with ATRX syndrome get this because of a genomic mutation, or whether these are specifically restricted to the tumor gliomas as somatic mutations. So the jury is out yet on it, but they have very specific treatment protocols which they seem to respond to, which is not like the general gliomas that are not related to ATRX. So this is a condition that can be made out by this wide and big mouth with upper and lower lips being wide. Now, there is another condition that looks similar, and that's more recognizable. And these are patients who have got Williams syndrome. So Williams syndrome also has a big, wide mouth. This is a condition that's caused by elastin gene mutations or a microdeletion that involves the elastin gene. And all of them have got this wide mouth with the teeth that are small and again could be widely spaced. And that stays for life, as you can see in an older child over here. The difference over here is that these children with Williams syndrome do not have the severe cognitive problems. Unlike the absent speech that is seen in most of the ATRX patients, these people have actually what is called a cocktail party manner. So they speak more than they should. And most of it is non-related to the situation. And so it's sometimes called a cocktail party manner of speaking. And some of them have hypercalcemia along with a very specific cardiac defect, which is the supravalvular aortic stenosis. So how do we diagnose this? This is another easy FISH test. You put the elastin probe, which is marked by the red. This is a normal signal where you have a 7 chromosome in 2 copies with 2 signals at the critical region. And here you have a missing signal showing that it is a deletion of 7q. The difference between them is again related to the mouth. This is a Williams mouth. The upper and the lower lip are both thick and sometimes enclose teeth that are widely spaced and could be small in size. The same applies to the teeth of ATRX, but what you can see constantly is that they have a dented, inverted V-shaped mouth with a very short philtrum, which is constant for the ATRX. So the shape of the mouth would be the diagnostic feature if you have any doubts about what you're trying to diagnose just by visual appearance. Talking about teeth, this was a boy. I come across this sometimes, not as commonly. A 16-year-old male who had been brought because he was the shortest person in his family. He had 3 strapping tall sisters, and he had moderate learning difficulty. He was still managing in mainstream school, but not very well. There's a little bit of facial asymmetry, possibly caused by lower motor neuron facial weakness, but there was very less else to see. But when he smiled, what you can see is this single central incisor tooth in the maxillary dentition. And this, if you look back at the face, is accompanied by a degree of hypotelorism. So the gap between 2 eyes is usually equivalent to the width of 1 eye. And anything less than that is hypotelorism. And this is known as the solitary median maxillary central sinus, or SMMCI, a mouthful of a syndrome. And it affects both the primary and the secondary dentition. Why is it important? Because it is a predictor of holoprosencephaly. Now, it's usually associated with other midline defects, including hypotelorism, quite severe choanal atresia, which can manifest at birth with breathing difficulties, palate abnormalities, and hypopituitarism, which was happening in our patient and causing the short stature in him. The defect appears to be between day 35 and 38 post-conception. And most times, if you have a familial occurrence, it's caused by the sonic hedgehog gene, which is inherited in an autosomal dominant pattern. Why is it important? Because somebody as mildly affected as the boy that we saw can have an offspring with very severe holoprosencephaly, which may end up in early death, or very severe intellectual disability. So it's very important to pick up right from a single central incisor. We have to be careful to ask the family that it's not a mesiodens, which is a tiny triangular midline tooth, or an extracted tooth, or something that has been done orthodontically, and it exists in both the primary and the secondary dentition, and only affects the maxillary palate. It does not appear in the mandible at all. So an easy way to look at something that may be much more intimately affecting the individual. Now, I'm fond of the ear because ear is affected in most abnormalities that are related to genetic syndromes. The ear is also the most difficult part. External ear is most difficult to describe. And what you can see is that there is a lot of parts of the ear that have got different names. But here I would like to just focus on the central cone-like thing, which is called the concha, after a shell. So this part is the concha of the ear. And in the concha of the ear, you usually have a cup-like depression. Here you can see an individual. There's a lateral crus that extends from one end of the ear to the other end of the concha, and similarly in the opposite side. For somebody like me who's looking for conditions, this is usually associated with craniosynostosis syndromes, those that affect the coronal sutures mainly. So whether you have a Moenke syndrome, and you'll see that he's got a lateral crus here. This is another child with coronal suture synostosis. These are people with Sartre-Shortzen syndrome, and you can see the lateral crus that goes end to end, and an easy thing to see if you're looking at, and this is Crouzon syndrome. These are other undiagnosed. I'm sorry, the hair covers the face, but you will appreciate that there is a transverse crus going through this mother and child combination who have all got craniosynostosis syndrome. Most people who have got moderately involved craniosynostosis, whether it is syndromic or non-syndromic, will have this transverse crus through the ear and just needs to be looked out for. So what are the neurological issues with craniosynostosis? As you're aware, it's a birth defect of the skull, characterized by premature closure of one or more cranial sutures. It can cause increased intracranial pressure, secondary hydrocephalus, and in later stages, obstructive sleep apnea. There's restriction of brain development if it affects multiple sutures, and cosmetically, it can cause a misshapen skull, which seems to be the problem that most families find most difficult to deal with. As far as we are concerned, the more the sutures involved, the earlier the onset of sutural fusion, and whether it is associated with a craniosynostosis syndrome, more is the likelihood of having a neurocognitive disability, which is estimated to be in 30% of individuals with a craniosynostosis syndrome. So the majority of the syndromes are caused by this group of genes which are called the FGFRs, which are structurally similar but have very distinct spots on them where they have recurrent mutations in specific syndromes. Only about 8% of craniosynostosis can be familial or syndromic, but there are at least 200 different syndromes that have been described. And in the last 10 or 15 years, there's quite a lot of literature describing newer and newer genes that may cause it. But there are about half a dozen syndromes with craniosynostosis, and most of them are listed out here that appear most commonly. Many of them are compatible with life, unlike thanatophoric and the very severe part of Pfeiffer syndrome. And some of them can be associated with digital and palatal abnormalities and with, of course, cognitive issues. Not difficult to diagnose and not difficult to test for if you know what you're looking for, but easy to pick up if you see the transverse crust in the ear, and easy to think about it before you do the first skull X-ray or CT scan. Lastly, of course, the most important thing that most neurologists treat is epilepsy in different forms. And I'm by no means going to cover all the ends of epilepsy, but this is just a small, brief review of the potassium channelopathies. There are sodium channelopathies, there are potassium channelopathies, and to some extent the calcium channelopathies. But there is this extremely excellent review that's been written in 2020, and I would urge you to have a look at it if you want to look at some of these syndromic forms of the potassium channelopathies. And these are just some of the syndromes I thought I'd show you pictures of. So this is Anderson-Tawil syndrome, where there is very, very characteristic U forms on the ECG. And what you can see is a number of facial dysmorphisms of this tiny face with micrognathia and fifth finger clinodactyly. What we see a little bit more frequently is the Cantu syndrome, which has got huge hirsutism, both on the face and on the body, and they have accompanying cardiac disease. And they can also have these potassium channelopathies caused by a dominant gene in ABCC9. These two people have an identical syndrome, which has been recently labeled as the Boer-Tartaglia syndrome. And however much of a tongue twister it sounds like, you can see that they have got this very hypertrophied gums, which appear very early in life, and they've got quite prominent hairlines, which makes it easy for you to see it. You can actually visualize it. And this is actually an imprinted gene defect in KCNK9, and there's a specific treatment for it if you have to control the seizures that they are sensitive to. And of course, the Burke-Barrel syndrome, which has got an extremely short philtrum with tented upper lips. So the list goes on and on. There are at least 80 potassium channelopathies alone. Not all of them may be syndromic, but some of them can be picked up because these are rare conditions. Just identifying key features helps towards diagnosis. I would like to say that sometimes, even though you pick up the primary syndrome just by looking at it, here's a Down syndrome, what you can see is that the child has got jaundice. He also has this very keratotic skin lesions, which forms phrinoderma. That's a ricketic rosy. And this was a child who had jaundice because of chronic untreated hypothyroidism. And the secondary morbidities also add to the dysmorphology of syndromes and needs to be looked out for. Occasionally in our societies where we have got multiple consanguineous marriages, you can have two syndromes coexisting in each other. And it's so important to not forget to diagnose the second one and to see the person in detail. So what do? We approach the dysmorphic child in a very systematic way. The most people would do this. You take the history, the pedigree, ask about consanguinity, other affected members, and do a detailed examination. It always starts with anthropometry, whether it's prenatal or postnatal. You examine always from head to toe. You don't forget, although some key features may stick out at you, you still do a detailed head to toe examination. Never miss out the oral cavity, the back of the child, genitalia, and open eyes in an infant, because sometimes an open eye can show you cataracts, ophthalmos, a whole lot of other things. You have to observe a child over time because it gives you key messages about how the child is developing. See all the relevant features and make a list of them so that they are documented. Look at family photographs where available and then plan your tests. The tests can be anything. It could be metabolic, it could be extended genetic, and colleagues are absolutely necessary people to give you wisdom about what they've seen, because none of us can see all of the syndromes that exist. And therefore, we rely on not only the internet and databases, but on colleagues with more experience. And you have to consider all options before you label a person with a particular name. It's very difficult to take away a diagnosis. And in the era of next-gen sequencing, where you can send off a sample and get a VUS, a variant of unknown significance, it makes it very difficult to wonder whether this is or isn't. And that's where your deep phenotyping will help you make a diagnosis in a patient. And for people like me who find dysmorphology interesting, I would like to finish with saying that there's nothing more interesting than the landscape of the human face, which helps you in so many different ways to identify the underlying disorder. Thank you very much.
Thank you, madam. Such an excellent talk and explaining in simple ways how to identify various syndrome and how to select the various types of tests based on examination. So we'll take questions at the end of 3 talks, I think. Is it? Hello?
Yeah, so we'll take questions at the end, but please type your questions in the chat box so that we can take them in the end. Thank you, Dr. Meenakshi, for elaborating on the importance of dysmorphology in neurological disorders. It's my pleasure now to introduce Dr. Ratna. Dr. Ratna is a long-term colleague of mine, and she is a MD in Pediatrics from Armed Forces Medical College and a DM in Medical Genetics from Sanjay Gandhi Postgraduate Institute, Lucknow. He is awardee of the prestigious Dr. I.C. Verma Outstanding Researcher Award in 2019. He is member of the Undiagnosed Diseases International, member of the Diagnostics Scientific Committee International Rare Diseases Consortium, and also of the DHR ICMR Government of India Task Force. And she has a lot of interest in diagnosing and counseling and treatment of rare disorders. And I invite Dr. Ratna to present her talk today.
Thank you very much, Ashwin. And good evening, everybody. I will, without wasting much time, start with my presentation. Can you see my slides?
Yes.
Yes, we can.
You can see my slides?
Yes, yes.
Okay. So I've been asked to speak about the eye in inborn errors of metabolism, and essentially in this session where we are linking phenotypes to diagnosis and management. And Dr. Meenakshi has really beautifully, I always enjoy hearing her talks on dysmorphology because I still learn so much from her. And so she's introduced you to the concept of dysmorphology and looking at things carefully. And I'm just going to take one aspect of that and talk about the eye. Now, and this is really limited to inborn errors of metabolism. So the start of the journey of the eye in IEMs was really way back in 1908, where Sir Archibald Garrod used alkaptonuria to present his real theory about IEMs. Nothing was known about that. And he had observed, he was actually a biochemist, and he was fascinated by urine. And he had observed a change in color in the urine of some patients, as also dark spots in the sclera and the cornea. And he realized that homogentisic acid, and you can see the pathway here, where there is a block in this enzyme and therefore accumulation of a precursor metabolite. And this has already been introduced in the previous talks, these concepts. And that resulted in that. And this was the first identification of the eye as a part of a multisystemic involvement in an inborn error of metabolism. So alkaptonuria is really associated with ochronosis, which is this bluish and black pigmentation of the connective tissue, whether it is in the eye or over the ear. And it is because of accumulation and deposition of homogenesic acid. And what we see in the urine is when the urine is exposed and there is oxidation, so you get this melanin-like product. And over the years, the main impact of this is not really related to the change in color, but it causes a spondyloarthropathy because of very severe pain and arthritis that happens. And now, after many, many years of understanding the basis behind this disorder, there has been a lot of work which has been done on the treatment with nitazoxanide. And there are many papers that have come out recently by Professor Lakshmi Narayanan, who has spent a lot of time working on these patients and the use of nitazoxanide, which essentially prevents the development, the accumulation of the precursor metabolites. Of course, there still remain many unanswered questions related to this, but only a long time follow-up of these patients who are receiving this treatment, which is also used for tyrosinemia, will give us some idea on how it impacts patients where it is started late in disease. So the development of the eye really is from mesenchyme, ectoderm, and neural crest cells. And this becomes important because to understand what is deposited where, in which part, and that, that results in the abnormality that we see. So what is really crucial is that it has a great link with the central nervous system. And therefore, there is a lot of homology between an abnormality of the central nervous system and the involvement of the eye in various diseases that affect the brain. And the greatest thing about this is the ease of access of the eye that really makes it an important target to evaluate and to make a diagnosis. So there are two primary scenarios where involvement of the eye, how we view the involvement of the eye in IEMs. One is there is a known metabolic disorder, and the eye involvement is within the spectrum of the manifestations. And the second is that there is a primary eye abnormality, and because of that primary eye abnormality, we suspect the metabolic disorder, and this would be illustrated in the subsequent slides. And why is it so important to pick up visual impairment early? So ideally, we should detect it within the first few weeks of life, because if it is delayed, it results in a severe visual impairment, and the child would, not make contact and would have a long-term impact on the visual acuity of the child. There are some situations where if you do a careful examination, how we are taught, you will identify the abnormality and link it to a disorder by doing the relevant investigation, like we all know for cataract and galactosemia. There are many situations, and we should know that the examination is normal, but within a spectrum of a phenotype, we should suspect involvement of the eye and do the appropriate test like an ERG or a VEP. And an example of this is the peroxisomal disorders. So what I'm really going to cover in my talk are related to abnormalities within eye structure, and we are going to go not from head to toe, but from anterior to posterior, and abnormalities of oculomotor function. So within this scenario, it again starts from the history, which would involve the clinical feature, the clinical history of presenting complaints and present illness, the progress, developmental history, the family history, and the eye symptoms. So you would not restrict it only to the eye. Use of the ophthalmoscope, whether to see directly, or we do a fundoscope examination with that. For some things, we know that we require slit lamp examination. And then, of course, you have the neurophysiological investigations of ERG and VEP. So I start with the cornea, because the cornea is really a great example of a window to various disorders. Most of them have treatment. And the advantage is the ease of corneal examination. Now, in most of the storage disorders, the cornea is very sensitive to the abnormal product being stored It could be a generalized all over the cornea, or it could be in various parts. And specifically, if it's from the blood, it is in the periphery of the cornea. And you would see this either with a torch or with an ophthalmoscope. And at times, if the changes are subtle, we need a slit lamp examination. And your symptom would be photophobia, and the sign is corneal clouding. And there is a group of disorders where abnormality of the cornea gives us a clue. And we start with the most common, which is mucopolysaccharidosis, where we have corneal opacity. And you know that this occurs in type 1 significantly. In type 2, you might see some by a slit lamp examination, but not by a naked eye. Type 4, 6, and 7. And in type 3, you do not have corneal opacity, and you may not even see anything on a slit lamp examination. And then there are these other disorders that I have listed where you do find opacities in the cornea. And then this is a little cohort study that we had done. And if you see, the last column is of the patients where corneal opacities are predominantly present in MPS 1, and the one on top is MPS 6. Sometimes, because there was only really very few patients with MPS 4, so probably that was not picked up, and routinely we do not do a slit lamp examination. The other eye involvement in MPS would include the retina, where you could have retinopathy, optic neuropathy, and glaucoma. So you know that each one of these would need to be evaluated for, otherwise you would miss this unless there is an absolute loss of vision. So that is why, in addition to the corneal clouding, a long-time examination and a follow-up of these patients becomes very important. Then I go to the second lysosomal storage disorder, which is Fabry disease, which is an X-linked disease. Now here there is deficiency of the acid alpha galactosidase enzyme. And what we see very characteristic here by a slit lamp examination is the cornea verticillata. Now, it has no impact on vision, so you have to examine it where you're suspecting these patients. And you can, because it's an X-linked disorder, this is a very easy and an important clue to pick up carrier females and other patients who may not have clinically manifested the entire phenotype of this disorder. And you can see that this cornea verticillata are these lines, the fine, straight or curved lines that are radiating out from the cornea. There is a phenocopy, but these are not drugs that are used very frequently in children. In addition, they can have cataracts and conjunctival vascular lesions. And there have also been a study that has correlated severe mutations to be associated with the development of cornea verticillata, because you can see that it is not present in all the patients. Now, this was an interesting study from India. It was a multi-center study that was headed by Dr. Sheila Namputri, where she put together the genotype and the clinical course of 54 patients. It's sad to say that from these, 12 of them were not even evaluated for this phenotype, but most of them, it was one of the common phenotypes that was present. So from the, if you take it from the total, it was 46%, but from those who were actually, in whom it was looked at, it was 69%. So this is a very early sign, and it also helps us in picking up these patients early, because you can see from this study, there was a diagnostic delay of as much as 11 to 12 years in making a diagnosis. And the reason for that is, one, because of the rarity of these genetic disorders, and two, that it has multi-system involvement and every patient may not present in a similar manner. And that is why the diagnosis is missed and it's delayed. Another very important clue to making a diagnosis. Now look at this family. This boy had come because at 28 years, he was diagnosed to have cirrhosis, which was recent onset. He had only noted icterus from the last 3 months. And when that was examined and evaluated, he already had varices. He was very worried because his younger brother had died at 24 years, also with a diagnosis of cirrhosis and no etiological cause for that. On direct questioning, he said, well, yes, there has been a little change in my handwriting. I am having some sleep disturbances, but I put it down to the fact that my brother had recently died. And when we examined him, he had minimal tremors on examination. There were no other neurological signs or symptoms in this. And we ordered a KF ring examination because that is one of the first things we know. If two brothers have cirrhosis, it is an autosomal recessive disorder and very, very subtle CNS abnormalities. And we identified this KF ring, which is the single most diagnostic sign in Wilson disease. We know that even in pre-symptomatic patients, you may not have abnormalities in the serum ceruloplasmin and the copper, but if you find the KF ring, you know that you've got your diagnosis. Because over 95% of patients with neurological symptoms and about 40 to 50% of those with a liver disease do have this sign. And we then just went ahead and did the mutation studies, confirmed the diagnosis because this was late onset and with a hepatic involvement predominantly. Very, very minimal signs, and he was started on treatment. So you realize that these very simple things, which don't cost a lot of money, can lead you into making a definite diagnosis. Now here we have another patient where the family came into our center for prenatal diagnosis. So this boy from 9 months was not doing well. He was apparently well till then. And he had vomiting, constipation, there was weight loss along with some change in behavior, polyuria and polydipsia. And for the last few months, he had not developed very well. There was no corneal opacity. The ultrasound had shown bilateral hydronephrosis with an increased renal parenchymal echogenicity. And the various investigations confirmed that he had a renal Fanconi syndrome. He also had rickets. And at 3 years, he was diagnosed to have cystinosis. This is not his picture. I don't have his picture, but I took this to show you that when we do this examination, you identify the cystine deposition in the form of these bands that are seen on the cornea and the conjunctiva. And he was also started on treatment at AIIMS with Cystagon. And over a period of time with treatment and at times even the local topical cysteamine drops, there is a reduction in the deposition and an improvement in the corneal features, of course, along with the general systemic improvement. So we know that the early onset phenotype of this is nephropathic. So when you have renal tubular acidosis, because this is a treatable cause, it's important to keep this in mind, do a simple slit lamp examination and to get your diagnosis. In fact, there is a later onset phenotype, which is purely ocular. You may not have any other features. Now, this is the work of one of our PhD students, Nitika, who worked very hard with these families. And I'm going to show you how just making a diagnosis in one patient. Now, this was a patient, he had an MI at 37 years. Look at his eyes. He's got this arcus, which was present when he was much younger and not at 63. He's got very high cholesterol and he had been on statins because when they come with a young MI, they do the cholesterol and they start the statins. But what is missing is this family history. This is where he was. This is where she started from. And then identified so many affected individuals with high cholesterol. So this is familial hypercholesteremia. And there are also as many people in the previous generation who died of MIs at a younger, which happened at a younger age. So this familial hypercholesteremia can be autosomal dominant. It's hugely underdiagnosed and undertreated, as you can see in the previous family history that I've shown you. And because it is so common, it is not unusual to have two people with hypercholesteremia, the heterozygous phenotype, who get married. And then they can have a child with homozygous FH, which is much more severe. Most of the mutations occur because of changes in 3 genes, the ApoB, the LDLR, and the PCSK9. We now have specific treatment that is related to this gene. And there are many more. in her cohort, in 47%, the mutations were identified, the commonest being the LDLR gene. So it's actually very often we realize the magnitude of a problem when somebody is working on a specific problem. Till then, nobody had even thought about the extent of hypercholesteremia, and especially looking at one family and identifying so many other individuals who would do well with the early initiation of therapy to decrease morbidity and mortality. So in addition to this disorder of lipoprotein metabolism, we also have Tangier disease. I've never seen a patient, but this is really because of low levels of high density lipoprotein. And it's very easy to diagnose because of the presence of these large orange crystals because of the deposition of cholesterol ester, especially in the reticular endothelial system, not crystal, the large orange tonsils, organomegaly, and you have corneal opacities in these patients. And you can also have an exposure keratopathy. Then I come to a very large group of cataract, very important to diagnose early, simple to diagnose, and important to treat because if it is untreated, it results in significant problems. The common etiologies include infection, metabolic disorders, and various genetically transmitted syndromes. And you can see here that 50% of congenital cataracts are inherited. There are more than 200 genetic syndromes and over 115 genes. So I'm just going to delve into some of the common ones, which are important to identify and treat. And I bring this here. It may not have significant neurological manifestations, but very important to diagnose early because it is a very easily treatable disorder. So this was this 1-month boy who presented with abdominal distension, had bilateral congenital cataract, a little bit of jaundice, and diagnosed to have galactosemia. And I'm going to tell you in a subsequent slide what would present at birth, what would present a little later in infancy and childhood, because you would make your diagnosis, differential diagnosis, based on that. And just to complete galactosemia, when we are making a diagnosis, I think it's important not to save money because you're treating a child for life. Sometimes we just do the GALT levels. They could be borderline. We stop, we give them galactose-free diet. We really don't know whether the child had which kind of galactosemia, what are the metabolites, what are we going to follow. So it's important before we change the diet of the patient to do the metabolites of galactose and galactose 1-phosphate, because with this you would pick up, you're very sure that there is galactosemia because of deficiency of GALT. And in case galactose 1-phosphate is normal and galactose is high, and there is an isolated cataract, you know that you're dealing with galactosemia. Without a complete workup, you would miss many things. Then there are some disorders which are identified through patterns. It is a pattern which tells us this is the disorder, and we do the specific metabolic investigation that is required to confirm that pattern diagnosis. And an example of this is rhizomelic chondrodysplasia punctata. So you have rhizomelia, you have punctate calcification that you can see here. You have dysmorphism. It's like a face that, with mid-facial hypoplasia and a little bit of hypertelorism. You can have ichthyosis. There is cataract that is present at birth, and there would be seizures and intellectual disability. In these patients, the VLCFA analysis is normal. You have to do the plasma phytanic acid, which is elevated, and you could also do the plasmalogens. And this is the change in the gene, which causes RCDP. And these are recessive disorders. Even though the prognosis may not be good, they may die early, but it's important to do the complete evaluation because you have to prevent recurrence in a subsequent pregnancy and counsel the families properly. And you cannot do that until you have a complete workup like this. Now, these are the cataracts which would be present at birth. So it would be the Conradi-Hunanman syndrome, which again would have some skeletal abnormalities, and there is asymmetry in these patients. Cocaine syndrome, which is a neurodegenerative disorder with multi-system involvement, severe failure to thrive, contractures at birth, and eye changes. Lowy syndrome, the peroxisomal biogenesis disorders, the RCDP I've talked about, and Senger syndrome, which I'll talk about a little later. Now, this is the hallmark of the biogenesis disorders, Zellweger syndrome, which is associated with marked psychomotor retardation, a Down syndrome-like facies, hypotonia, intractable seizures, white matter abnormalities on the MRI, hepatorenal anomaly, so it's called the cerebrohepatorenal syndrome. And in the eye, we could have corneal clouding, cataracts, pigmentary retinopathy, and a pale optic disc. And here, if you do the very long, and actually these features may come up much later. An abnormal ERG is something that you pick up early, even before all these signs are there in the child. You could have very long chain. Here there is the levels of the VLCFA are very elevated, and as are the phytanic acid and the pristanic acid, and the RBC plasmalogen levels are low. Now this is actually a sad misdiagnosis. In this family, there were two boys affected. Both of them had congenital cataract. The younger boy had died. We don't know the reason why. Possibly because of aspiration. This child had come into the clinic. He was 4 years old when he came in. He had had visual impairment since 3 months of age, and he had a cataract that had been operated. But at that point in time, because there was no obvious delay, he had not been evaluated and there was no family history. Over a period of time, he had severe global developmental delay, and he also had failure to thrive. His brain MRI had shown hyperintensities in the periventricular regions, and the rest of the investigations which you do for cataract were normal. But what he really had was Lowy syndrome, and something that you could have treated if we had identified and at least done a urine examination at the time his cataract was operated. So their cataracts are a hallmark, it's present at birth, and in addition, they have the other phenotype as we see in this family. So these are the age of presentations of cataracts, and what I've put in bold are those disorders that are treatable. So you could have them after birth, you see them in the first month or a little later, and these are the disorders that you see in childhood, and these are freely available in books. Now this is again a pattern. If you've seen it once, you don't forget. And these are two families who had cataract, global developmental delay, high lactate, and cardiomyopathy. So this is Senger syndrome, and the triad of cataract with high lactate and cardiomyopathy gives away the diagnosis. It's a mitochondrial depletion syndrome because of a nuclear gene, and it's an autosomal recessive disorder. And even though the diagnosis is not easy, they have limited spans. By this now, I know that this child has also died. But what is important is we don't have to have a situation where multiple members are affected before we start thinking about genetic disorders. It's important to counsel the families for recurrence to reach a diagnosis. Now, this was a 43-year-old boy, a male who was admitted in my hospital. He was being evaluated. He actually came in for an unrelated reason, and it was the history that brought him to attention and a genetic referral. He had been operated for cataract at 3 years. He had mild intellectual disability. He had a progressive ataxia since 35 years, and he had these xanthomas. These are not his pictures, but representative pictures. And we thought of cerebrotendinous xanthomatosis, where in his case, the cholesterol was normal. It can be low, but the plasma cholesterol levels were elevated. And then the gene study was done. And this, as you all know, is a treatable disorder. And this is a review of 55 children of patients with CTX, and you see that 90% of them have cataract. So suspect, test, and identify is what we are doing. So we have a diagnostic approach for cataract, where in addition to the genetic causes, you have to look for other non-inherited causes of cataract, but evaluate for galactosemia. If there is dysmorphism, it might be a part of a chromosomal disorder. Do a urine for LOE, for Alport, look at the electrolytes, look at the urine amino acids, the plasma amino acids, CTX, and an enzyme and a molecular diagnosis. Finishing
Hello, Dr.
the
Ratna?
group, yes,
Can you?
yes,
please do that?
I'll be finished. So finishing the group of the lens, we have ectopia lenses, which could be syndromic, like you see here in this patient with Marfan syndrome, and in where there is an upward dislocation of the lens. And here below, we have homocystinuria. And again, treatable, needs an early diagnosis. 15 years is too late to do this entire spectrum. So where we have a cataract, you do a homocysteine level and you'll be able to get to your diagnosis. Cherry red spot is something we are all very familiar with. This is in sialidosis. This is our collection of patients with sialidosis type 2. It is present where it is present in a majority of them, but of course in type 1, it is present in all of them. And these, along with the cherry red spot, if there are these, you would think, or Mongolian spots, you would think of GM1. You have these nodules that are present over the joints and under the skin, you would think of Faber. You have the abnormalities in the MRI, it is GM2, gangliosidosis, so helping you make a diagnosis. Then retinitis pigmentosa is where there is a loss of photoreceptor function, and the diagnosis is essentially by pigmentary retinopathy. And again, it's a pattern. You have a pigmentary retinopathy or glistening white spots in the fundus, along with mild intellectual disability and ichthyosis and a spastic paraparesis. You know that it's Sjogren-Larsen syndrome. There is a host of metabolic disorders that are associated with pigmentary abnormalities in the retina, and the ones in bold are the ones that are amenable to treatment. Now, this is a family where this gentleman, the older uncle, was followed up as a fetal Hayden-Toyne syndrome for years until another child was born, and the family recognized some sort of similarity between them. And it is then that they came for evaluation. He himself had significant intellectual disability, and they were finally diagnosed to have alpha mannosidosis, which again is treatable. It may not be available here, but we could have prevented the birth of another child. And it was these pigmentary abnormalities, the optic disc involvement, the pallor, along with the phenotype, the hepatomegaly and the coarse facies, which led to the diagnosis and confirmation of this syndrome. So it was these are all lost opportunities for treatment. And this is a very typical picture of gyrate atrophy of the retina, where there are very high levels of ornithine because of a metabolic block, and this is deposited. And this is actually a giveaway for this diagnosis and doing a specific gene test for gyrate atrophy of the retina on the OAT gene. LON, I'm not going to allude to because this has already been covered in the previous mitochondrial section. And finally, we have optic atrophy, which is a feature, And my last one is about movements of the eye. Now, we could have abnormalities in the neonatal period and early infancy, those that come in later, and those in adulthood. The common ones are, like in this child, we have this is a patient with neuronopathic Gaucher disease. So the horizontal saccades are limited. And here we have a young child with an oculogyric crisis. And we are evaluating this child for a neurotransmitter disorder. And this is a patient with limitation of vertical saccades. And he has Niemann-Pick C disease. So it's actually looking at the eye which gives away which gives away your diagnosis.
Excuse me, Dr. Ratna. You are muted.
Sorry, I think I became mute. So the aim here was only to bring to attention that simple ocular abnormalities and a simple examination can alert to a possible diagnosis of an IEM, and interventions you can do early, and if there are no interventions, we can prevent a recurrence for better outcomes. So thank you very much, and my acknowledgements to the patients and their families and my colleagues and staff at Gangaram Hospital.
Thank you, Dr. Ratna. That was a elaborate information on such a small organ, but has so much of importance in genetics as well as neurologists per se. So again, I tell everyone, please type in your questions in the chat box, and Dr. Raju can now introduce the third speaker.
So, good evening to all. So now we will be going to next talk on Paediatric syndrome. So talk will be given by Dr. Andy. She will not be, it is a recorded talk because she was not available for the talk. So she's a professor of pediatric and developmental pediatrician and medical director at Mind Institute, University of California. And she's trained in MD and FAAP in pediatrics at Stanford University. She had a special interest in Fragile X syndrome and Fragile X syndrome, tremors, ataxia syndrome, Rett syndrome, and other autistic disorders. She got various awards. So I'll be, you'll be giving the recorded talk on autism, on Fragile X syndrome.
Is it audible now?
Yes.
Yes, it is audible.
Yeah.
I'll play it again.
Hello, Mr. Prasanna. Hello.
Yeah.
Hello. No, people are not able to hear. I think screen is frozen. Me too.
Shriya,
Yes, sir.
are you there?
Yes, sir. Yes,
We are not
sir.
able to hear.
Only the screen is visible, but
No audio.
Okay. 1 second.
can begin from the beginning.
Were you able to hear
Nothing.
No.
in the
Nothing.
beginning?
No audio.
We are able to hear only you, Shreya. We can't hear Professor Hageman.
Ma'am, I have just uploaded the video on the screen, and
Yeah,
that
but
is
the
how.
audio is not audible of the video. Only you are audible. Shreya,
Yes, sir.
any problem because we are not able to hear?
No, sir. The thing is, I have uploaded the video already, and automatically the audio should also be presented. But I
But
don't
it's
know
not
how.
happening.
Yeah, because like just
Do we
like in the previous video when Dr. Ratna presented the video, we could hear the.
Yeah,
Yeah.
but can you just once again, disconnect and then upload?
Sure, sir. Are you able to hear now, sir?
Oh. We can
Sorry,
only
are you-
hear you, Shreya. We can only hear you. Nothing else. Can hear her in the background a little bit. She's not very audible. Dr. Hageman is not very audible. Can you increase the volume, your volume, and just check?
Sure, sir. I have also selected over here to share sound. So, are you able to see my screen, sir?
Yes, we are able to see, but we are not able to hear.
No, the settings that I'm trying to change over here.
No, I'm not able to see.
Okay. So I've already selected. There's an option to share sound. I've selected that as well. So. Is Swami sir online, sir?
The pre.
Yes, I think there is some problem, Shreya. We are able to, I could hear some sound in between.
Okay, 1 second. I'll just play now.
Mutation,
Yes.
which has 55 to
Are we good?
From the
200
beginning.
repeats.
Okay,
Thank
sure.
you for this
Yeah.
invitation, and I will.
Is it fine?
Yes.
Yeah,
Okay,
it's fine.
Yeah, okay.
Shreya, again, I think you are muted. I mean, paused it. Shreya, remain unmuted, Shreya. If you mute yourself, we can't hear anything.
I have not muted myself, ma'am. It is unmuted.
Should on the video, I think.
We can't
Here
hear
it is
anything.
playing. No, ma'am, I have
But we
paused
can't
the.
hear anything.
1 second, ma'am. I'll just connect with you on my phone.
No, but it was very well connected, started, but I don't know, suddenly stopped.
Yeah, because here the video is playing and I can hear Dr. Randy talk completely fine. So
But
I don't know when it's stopped.
other than you.
1 second. Are you able to hear her now?
No.
No. Dr. Ashwin's mentioned that it is getting stuck at 4 seconds. Just forward a little bit and see.
Sure. Here now?
No.
Nothing.
Okay. How can we resolve this, ma'am? Because whatever settings are there are all fine.
We have IT backup. The video is
Do
we have IT backup?
Backup as in, ma'am, we have uploaded the video. I can hear the audio. In the beginning, you are able to hear the audio, but after a point, you're not able to hear the audio. All the settings are same. So how do we resolve this?
I don't know.
Yeah.
Hello?
Yeah.
Can you hear me?
Yes.
Who is this?
Dr. Jagdish Chinappa.
Yeah.
Yeah. Exit it completely.
Okay. Should I log out and then log in again?
Yeah, log out and re-log in.
Okay, sure, sir. Just.
Oh, so I'm really sorry. This is a nightmare. Hello? You called me and you're asking me hello? Okay, sure. Okay, bye.
Here's a picture of the Mind Institute. And
I have re-logged in. I'll just try to share the screen again. Are you able to view the screen?
Yes.
Okay, I'll play the.
Metabolic syndrome. I'm from the Mind Institute at University of California at Davis Medical Center.
like that.
For this invitation.
Sorry, Dr. Ann.
We can't hear you. Yeah, again, you just press the play button.
And I will talk about therapies for Fragile X syndrome. I'm from the Mind Institute at University of California at Davis Medical Center in Sacramento, California. And here's a picture of the Mind Institute and our team members. And we have done much work in different parts of the world, including India.
Hello.
And it is a pleasure to be here. I have funding from Zenurba.
Hello. Hello. Hello.
Shreya, it's stuck again.
It is playing, sir. For me, it is playing over here. Now?
No.
Why is it not playing? I have not pressed anything.
Shreya,
Your screen is paused. How?
why don't you ask Mr. Swami? Please wait from your laptop, Mr. Swami.
Shreya, I will share. Wait, I'll try from my side.
Sure, sir.
Yeah.
Sorry, sir.
I will try it. That's academic stuff. Hi. Is it done?
And from the Israeli Foundation for Metformin treatment in syndrome, and from
Is this fine
NIH for studying individual patient.
You want to leave? You can put it here. Yeah, 9. Yeah. 9. Yeah, understand.
He's in school now, Merchant Taylor. School. Yeah. And he joined. Yeah.
Which what happened?
At Merchant Taylor.
Oh, okay. So
Yeah.
just
So
like
we were in India. We just moved to UK. He come in March. South India, place called Kerala.
Oh, okay.
Yeah. So he just kind of beginner. He started coaching in India, but then the COVID came and didn't work. So now just getting some few sessions at Merchant Taylor's at the school. Carry it. Yeah.
And you enjoying it? Oh, that's amazing.
So we thought we might need some help with the falling. I think just get the action right, because some of the children with them are quite.
Prasanna, sir.
They've already been playing for some time.
So I want to give thanks to
Prasanna, sir.
Yes.
Could you please stop sharing your screen? I will share it one last time and check.
I'm not sharing anything.
Paediatric Society of India.
Swami, sir, could you please stop sharing the screen?
Diagnosed with Fragile X. And here is her contact information. So she is a wonderful person to contact in India.
I will try sharing one last time from my end.
Are you sharing anything?
Yes, sir. 1 second. Are you able to view it?
Then how can you share without informing this of me?
Hello.
So she is a wonderful person to contact in India,
Is it audible?
and she's located in Mumbai.
Yes, it is.
And so you are very lucky to have the Fragile X Society of India. So we're going to be talking about Fragile X syndrome, but this puts it in context. It's important to understand that the Fragile X mental retardation 1 gene, or FMR1 gene, has two forms. The pre-mutation, which has 55 to 200 CGG repeats. This is at the front end of the active portion of the gene. And the full mutation, which has greater than 200 repeats. And the full mutation has a process of methylation that turns off the gene so that there's little or no message produced, and that's what causes Fragile X syndrome. It's really the lack of FMRP, the protein produced by the gene. However, the pre-mutation, which is much more common, about 1 in 200 individuals, causes just the opposite. That means overactivity or overproduction of messenger RNA. Usually the level of protein is normal or slightly low, particularly in the upper end of the pre-mutation. But the excess messenger RNA produces several medical problems in many individuals with the pre-mutation, including early menopause or FAXPOI for women, meaning that they have menopause early before age 40. In aging, FAXTAS, or the Fragile X associated tremor ataxia syndrome, with a Parkinson's-like tremor and balance problems, seen in about 45% of males and 16% of females with the pre-mutation. It is also a very common cause of depression, anxiety, and other emotional difficulties, including chronic fatigue and chronic pain, and we call that FAXAND, or Fragile X-associated neuropsychiatric disorders. I'm not going to talk much about the pre-mutation because this is focused on the full mutation, but all of these disorders are called Fragile X disorders, or sometimes termed Fragile X spectrum disorders. Most individuals with the pre-mutation do very well in life because anxiety and depression can be treated well with medication. In childhood, sometimes we see ADHD or hyperactivity. Occasionally, we see autism or anxiety disorders. But most of the problems with the premutation occur in adulthood, including autoimmune problems in many women, such as hypothyroidism, fibromyalgia, and you can read more about these problems in premutation carriers. Individuals with FACS-TAS have tremor, usually with intention, with shaking of the hands. They can develop some aspects of brain atrophy or white matter disease. They also have inclusions in many of the neurons and astrocytes. And FACS-TAS can also occur in women, as I mentioned. So here's what the tremor looks like, and it's typically an intention tremor. So there are treatments for these problems. There are tremor treatments. We also recommend treatment for anxiety and depression with SSRIs. We also recommend antioxidants, treating hypertension or hypothyroidism, avoiding toxins, and also doing cognitive stimulation with aging, which is important for everybody who is aging. There's a medication called Anavex 2-73, which has been helpful in Alzheimer's and also Parkinson's disease dementia, and we hope to use it in FACS-TAS in the near future. It's also helpful in the Fragile X syndrome knockout mouse. So maybe in the future I will be reporting about Anavex treatment of both Fragile X and Fragile X syndrome. But it does many things, including improvement of mitochondrial problems, reducing inflammation, reducing oxidative stress, and enabling neuroprotection. But now we want to get on to Fragile X syndrome. Here are three brothers with Fragile X syndrome, and they nicely manifest many of the hand stereotypies, like hand mannerisms, poor eye contact. Hand biting is also very common, hand or finger biting. So these are some of the behavior problems. Many individuals with Fragile X syndrome can have aggressive outbursts. This is thought to be related to the GABA deficit. So GABA system is the inhibitory system in the brain, and this is underactive in Fragile X syndrome. So this interferes with habituation to sensory stimuli, and this can be measured by looking at the sweat response to environmental stimuli. Here on the left is a normal individual, and these bumps here demonstrate the sweat response to repetitive stimuli by these vertical lines. And individuals with Fragile X syndrome have more sweat response to environmental stimuli, whether it's tactile, olfactory, any kind of sensory stimuli. And it doesn't habituate over time, and this is what can lead to outbursts because they get overexcited with different types of sensory stimuli. And there's various ways we treat this. We do different sorts of therapy, occupational therapy, speech and language therapy, physical therapy. This is very important in early childhood, but also can be helpful even in adulthood. Prompt therapy is a tactile stimulation to the mouth, particularly for kids that are hypotonic in the face and around the mouth. And this can stimulate more language production, and you could read more about this on the web. Behavioral interventions such as applied behavioral analysis, ABA therapy, or the ESDM, Early Start Denver model, developed by Sally Rogers here for individuals with autism, also works well in Fragile X syndrome. You can read much more about behavioral interventions and therapy interventions at the fragilex.org website. We think antioxidants can be helpful for both individuals with Fragile X syndrome and the premutation, but there haven't been controlled trials of many of these antioxidants yet. Standard medications like stimulants, such as Ritalin or Concerta, Adderall, Focalin, etc. for ADHD can be helpful for the hyperactivity that occurs in the majority of boys with Fragile X syndrome, but also in about 30 to 50% of girls with Fragile X syndrome. Clonidine can help with sleep problems. Guanfacine can have a calming effect. Strattera or atypical antipsychotics like aripiprazole or Abilify or risperidone can be helpful, particularly for aggression or for anxiety. We usually use SSRIs such as sertraline or fluoxetine, but I'm going to talk about new targeted treatments today, including metformin and CBD or cannabidiol in this talk. I want to mention that sertraline has also been helpful in Fragile X syndrome. This is an SSRI or selective serotonin reuptake inhibitor. In a retrospective study that we did looking at those patients on sertraline compared to those patients off sertraline on the left, as you can see, expressive language trajectories were much better when they were treated with sertraline early on, including even at 1.5 to 2 years of age. And this is low dose sertraline, basically 5 or 2.5 milligrams per day. For both expressive language and receptive language, this retrospective study showed that the trajectory of language development was much better when they were treated with low dose sertraline. But then we did a controlled trial of low-dose sertraline for kids ages 2 to 6. And this graph here shows how many months better they were on sertraline compared to placebo. And on the Mullen scales of early development, you can see that the cognitive T-score was much better on sertraline. Visual reception was much better. Fine motor was significantly better. But what wasn't, we also saw better fine motor raw scores and combined age equivalent scores. But we expected to see language improvements, although we didn't see this they were better, but not significantly better for the overall group. But when we did a post hoc analysis, those that had a diagnosis of ASD plus Fragile X syndrome, which was about 60% of the population, when they were treated with sertraline, they were significantly better than when treated with placebo. So it may help those with autism even more than Fragile X syndrome without autism. So we typically use low-dose sertraline, again, just 2.5 to 5 milligrams, depending on the age, in young children with Fragile X syndrome. Now, the other targeted treatments I'm going to talk about usually relate to either having too much glutamate when there's an absence of FMRP, or too little GABA, that is downregulation of the GABA receptors. But there's also evidence that cyclic AMP is lower in those with Fragile X syndrome compared to controls. And so there's targeted treatments for all of these problems. There's also dysregulation in the dopamine pathway that improves when they go on stimulants. And there's also evidence of oxidative stress to the neurons, which is why we use antioxidants. But again, we need to have more controlled trials of different antioxidants in Fragile X syndrome. So this just shows some of the pathways that are dysregulated. And initially targeted treatments focused on the mGluR5 pathway that was shown to be overactive, excuse me, in Fragile X syndrome. And again, this involves this MEK-ERK pathway and also the PI3 kinase, PTEN, AKT, mTOR pathway that's overactive in Fragile X syndrome, but also GABA agonists such as arbaclofen have been tried in the past and did show benefit in Fragile X children, and there will be more studies of arbaclofen in the future. Now that arbaclofen was purchased by a new drug company, Upregulation of MMP9 has been studied with treatment with minocycline, and it was beneficial for individuals with Fragile X syndrome. The problem with minocycline is it can cause darkening of the teeth when used in childhood, particularly before 8 years of age. Ganaxolone, I'll talk about. Allopregnanolone, this stimulates the GABA A receptors. And I think an oral type of allopregnanolone has been developed and will be studied in the future. Acamprosate has preliminary data to show benefit, and this is also a GABA agonist, among other things. It also works on the mGluR5 system. But the original mGluR5 antagonist, such as AFQ-056, developed by Novartis, or also the Roche drug, RO491752, were not efficacious in the study of adults and adolescents with Fragile X syndrome. But now AFQ-056 has been studied in the Fragile X Learn trial. This has been done at multiple centers funded by NeuroNext, which is an NIH funding system. And in young children ages 3 to 6, we hope to see the data in the fall or in the coming year, because this study is coming to an end, to see if AFQ-056, together with an educational program called Parent Implemented Language Intervention, where we teach parents through Skype or through a video program how to stimulate language at home. And PLE has been successful on its own. I'll show you more about that later on in the talk. But we will find out whether this combination therapy is helpful for young children with Fragile X syndrome, hopefully late this year or early next year. So we look forward to those results, called the Fragile X Learn trial. Gaboxidol is a GABA A agonist, and this is studied in an open label study at multiple centers in individuals ages 12 to 22. In this open label study, as you can see here, it showed benefit in a variety of behavior measures on the ABC scale here, with significant p-values, but it needs to be studied in a controlled trial. So we hope to see that in the future too. So this GABA agonist, gaboxidol, will be studied in the future in a controlled trial. I want to talk a little bit about metformin, which is a widely available medication used to treat type 2 diabetes. It's also used to treat obesity. It is a glucophage, which means it eats glucose. That means it lowers the level of glucose in the blood. This is particularly important if you have diabetes, but the insulin receptor is overactive in Fragile X syndrome, and so this downregulates that insulin pathway. And it also increases AMPK, which is a protein that stimulates the mitochondria to work harder. It also lowers the PI3K, AKT, mTOR pathway, as I showed you before, was too overactive in Fragile X syndrome because the insulin receptor is overactive. And so metformin is a very old medication. It can be found in plants such as French lilac. It was used by the pharaohs in Egyptian times. There have been many writings, even in this papyrus from 1500 BC, when it was used to treat many problems, including excessive fluid, diabetes in the early times before diabetes was really understood. Again, it can help with overeating and obesity. So I first tried it in several patients with Fragile X that had this Prader-Willi phenotype. that is obesity with this lack of satiation after meals, where they keep eating after meals. This is seen in less than 10% of individuals with Fragile X syndrome, but can cause significant obesity. Metformin was also helpful in animal models for Fragile X, including the Drosophila Fragile X model, and even in the knockout mouse model, it rescued many features of Fragile X, including cognitive features. We found it was very helpful in a study of initially 7 patients with Fragile X syndrome that was published by Dietol in 2017. Metformin not only treats excessive glucose in the blood, but it can also help with high blood pressure. And it's actually preventative for many types of cancer, because when you downregulate the mTOR pathway, it downregulates VEGF and PAI1, which are proteins that stimulate growth. And that's why it's preventative for many types of cancer. It actually has 2 papers out now as to how it can be protective for macular degeneration. So it has many benefits, particularly in aging individuals. It has cerebral vascular benefits, and it can decrease some memory problems with aging. So this is very exciting. We are now carrying out a controlled trial of metformin in Fragile X syndrome. This is the study that was funded by the Israeli Foundation, a Canadian foundation. So this is occurring at 2 sites in Canada and at the Mind Institute. This is for individuals ages 6 to 25 with Fragile X syndrome. And we have a variety of outcome measures. We hope to finish this trial by the end of this year. We'll be enrolling patients through June and probably in July. This is a 4-month controlled trial. And at the end of this controlled trial, individuals can go on metformin for sure. But we have a lot of anecdotal evidence that metformin can be helpful in Fragile X syndrome. We've looked at it in young children between the ages of 2 to 7. This was published by Hazel Biag, B-I-A-G, in 2018, showing benefits on the Mullen. This was not a controlled trial. This was an open label trial, but it was helpful even in young children, but we go up slowly on the dose because one of the main side effects is diarrhea. And if you go up slowly on the dose of metformin, then usually individuals do not have problems with diarrhea. On the right here, you see the weight improvement in a 12-year-old boy with Prader-Willi phenotype of Fragile X, who improved his weight on metformin. He also was started on this medication before he went through puberty, and with puberty, he has normal sized testicles, so it may even be helpful for testicular size. And as most of you know, testicles can be enlarged in individuals with Fragile X syndrome after puberty, and that's called macroorchidism. We also know that IQ can decline over time in individuals with Fragile X syndrome. It's not that they lose skills, but their benefit in terms of cognitive development becomes more and more distant from the normal range over time. And that's why the IQ can go down. But here are 2 adult individuals treated with metformin for a year who had cognitive gains in both verbal IQ and full-scale IQ. That was very exciting to us also. Now, I want to switch gears and also mention that trofinetide, which is an IGF-1 analog, as shown here, insulin growth factor 1 has a tail on it called GPE, and this is the analog, which is the trofinetide drug. This was studied in the mouse model, and it was beneficial in the knockout mouse model, looking at ERK and AKT biomarkers. Trofinetide lowered these levels, so it works on the pathways that are overactive in Fragile X syndrome. It also lowers inflammation and cytokine levels. And this showed benefit in Fragile X syndrome. This was a few years ago when this was studied. It has since been shown to be beneficial in Rett syndrome at a higher dose, 200 milligram per kilogram twice a day. And this will be studied again in Fragile X syndrome at the higher dose in the near future. So this seems to be helpful in not only Fragile X syndrome, but also in Rett syndrome. And it may turn out to be helpful in other forms of autism. I want to talk about cannabidiol, or CBD. FMRP, the protein produced in individuals from the FMR1 gene and that is deficient in Fragile X syndrome, it actually controls the cannabinoid system in the brain. And CBD, or cannabidiol, which is not THC, is thought to be helpful for Fragile X syndrome. And this has been studied by Zynerba, which makes a topical ointment called CBD. And this comes in a foil packet, and you rub it on the skin. Although many individuals can get cannabidiol through the internet, the body's endogenous endocannabinoids called anandamide and 2-AG, they stimulate both the CB1 receptors 1 and 2, which are throughout the body, but also in the central nervous system. Both CBD1 particularly is on astrocytes, and CBD2 is on microglia. So normally these cannabinoids that are naturally produced are produced through the post-synapse, and they go into the synapse in the reverse of most neurotransmitters, but then they can block the expression of other neurotransmitters. So it works differently than what you see, but CBD has multiple effects. It can block pro-inflammatory proteins, and it stimulates anti-inflammation effects. It also can help with helping the mitochondria work better, and it has a variety of effects besides the inflammatory and anti-inflammatory benefits and the mitochondrial benefits. It also actually helps to block tetrahydrocannabinoid, or THC, which can lead to more psychotic symptoms in many individuals, particularly pre-mutation carriers, and it can block that effect. So we like CBD, but we don't like THC. So we don't recommend smoking marijuana, but using CBD products that have little or no THC, we think is important. And this controlled trial called Connect Fragile X study was funded by Zynerba, looking at their topical treatment. And this was a topical treatment of either 250 milligrams to 500 milligrams daily based on weight compared to placebo. And then they could go on an open label extension. And this controlled trial did demonstrate benefits, but mainly in those with Fragile X syndrome that were fully methylated. And so in the full analysis, although there were benefits, it wasn't quite significant compared to placebo in the full analysis group, but in those that were fully methylated, it did show a significant difference for social avoidance and irritability, and also in the parent rating for the Clinical Global Improvement Scale for social avoidance, social interaction, and disruptive behavior, it was significant.
Randy.
And an open label, I see I'm wrapping up here.
Yeah.
In an open label in ASD by Zynerba, it showed benefit, and so there will be more controlled trials in individuals with autism. CBD has also been shown to be beneficial in certain types of seizures, such as Dravet and Lennox-Gastaut, as many of you neurologists already know. CBD looks like it may be helpful in neurodegenerative disorders like Parkinson's disease. It has not yet been tried in FACS tests. I also want to mention that Tetra, which makes BPN 14770 in a controlled trial, it was helpful for adults with Fragile X. This increases cyclic AMP Fragile syndrome, and this helped cognition using the NIH toolbox that David Hessel modified for those with intellectual deficits. So reading recognition, picture vocabulary, and the crystallized composite score, along with visual analog showing benefits in language and daily functioning. This got many people. This Tetra drug will be studied in multiple centers beginning, I think, late summer or fall for both children and adults with Fragile X syndrome. I have to wrap up here, but bumetanide lowers stress hormone cortisol, and this is being studied in Australia called XANA-FX in a phase 2 trial. And I also want to say that educational endeavors such as parent-implemented language intervention could be has been shown to be helpful for those with Fragile X, particularly in early types of cognitive measures such as CogMed and different types of apps for learning that Maria Diaz has published on. All of these we think can help with Fragile X. We're going to have a stem cell and gene therapy conference at the Mind Institute that you can sign up for through this website shown down here. So gene therapy will come to Fragile X maybe next year or the year after. So this is very exciting. You can hear about this at our conference. And we also have a pre-mutation conference in New Zealand in March of 2022. So you can sign up for both of these conferences. And I want to thank all of my collaborators, and I think I'm out of time. So I'm going to end this and answer questions that you may have.
Thank you.
Thank you, Dr. Hageman. That was wonderful. That was something that gave hope, and that's exactly what we are looking for. Thank you so much. When you were saying, because coming from a child neurology background and from a clinical background, it is exciting to see that there may be many molecules that may work out. So when you mentioned metformin, because we've had a lot of excitement this January this year with metformin, angiomyolipoma, tuberous sclerosis. Do you think we are heading that way? Or do you think we are heading that way? How much should we be stopping?
Oh, yes. I mean, we've seen a lot of anecdotal benefits from metformin in patients that we've treated clinically, because it's very available clinically.
Yeah.
And we will have the results of our control trial, but it's definitely helpful. We'll find out for how many it is helpful for. Our outcome measures include both cognition with the NIH toolbox and language. It seems to stimulate more language. So conversations can improve, we think. We think it can help with macroorchidism if started before puberty, and maybe help with excessive weight gain for those that have a Prader-Willi phenotype. So we think there's a lot of benefits for metformin. We haven't studied it yet in carriers, but I know of several carriers that have noticed benefit with metformin. So we need to do a controlled trial in carriers too. I think it can be helpful for the general population, being prophylactic for tumors. In fact, I take metformin myself, and I'm not diabetic. I take it for tumor protection.
That sounds like something which is very doable and at a wait and watch space. But because we treat children, what's the youngest child that you've seen who's been put on metformin for a non-traditional application such as this?
So I have started it in young children, even at age 2, but at a very low dose, like 50 milligrams, first once a day and then going up to twice a day. You can gradually increase the dose.
Dr. Ryan? Yeah. So, Dr. Raju, please take it.
We hand it over to our moderators now.
Okay.
Sure, ma'am. For the questions were asked in the chat box.
Yeah,
To Dr. Ashwin and Dr. Vaikund Raju.
Yes, there are a few questions for Dr. Meenakshi Bhatt. The first question is, what is your experience with PACE2 gene application to analyze these dysmorphic children?
So I think that was Dr. Gauri who said that. I've tried the PACE2 gene application, and because they homogenize faces, and also because they have mostly, I think, Caucasian faces, it's not really very helpful in making diagnosis. However, they have what was the old London Dysmorphology database attached to the PACE2 gene application. And that's much more helpful, where you can put in certain dysmorphic features and it gives you a short list of diagnoses. So PACE2 gene, not very helpful.
Thank you, madam. So next question is a very commonly asked question. For a child with dysmorphism, which test has a higher yield, NGS or microarray, which should be the first test?
So I think traditionally, most people would say that array would be the first thing that you would do, and probably at least a 750K array. But in populations like ours over here in the south, where you've got high levels of consanguinity, sometimes it's this confounding effect of having areas of homozygosity which show up. And then you don't get a very clear answer on that. So as things get more, I think in another couple of years, we won't be choosing, we'll be doing both together, array with whole genome sequencing. But traditionally, it's array that is expected to be the first line of testing.
Thank you, madam. One more question. So what would be an ideal approach to a VS or mutation on NGS where the prevalence is not clear apart from phenotypic correlation? Also, there is any certain vertical depth resolution on NGS which can replace the need for an additional microarray?
I don't know the answer to that. I don't know that there's a simple answer to resolving a VUS and being sure whether it is pathogenic for that family or otherwise, because a lot of us do not have the luxury of looking at functional studies. So I'm not quite sure how we do it, and each case needs to be worked up on a case-by-case basis. As the simplest thing we try to do is try to see how much the phenotype matches where the location of the mutation is within the gene, whether it's a critical area, whether it's preserved and predicted to be pathogenic. I'm not sure about the depth on how we would predict it. But also you would see whether segregation with parents is relevant and informative. So I think these are some of the things we're doing in the clinical setting. Much of it, the rest becomes research.
No, thank you, madam.
Thank you.
So Dr. Ashwin for questions on Ratnapur.
So there was one question regarding this HCQ, which I suppose is hydroxychloroquine. Does it lead to cornea verticillata? Madam, your mic is mute.
Sorry. It is reported as a phenocopy. I have no personal experience of that, but I did read that it is on long-term use. So that's why I had said in my talk that we really don't give it for very long-term, that it can cause verticillata, cornea verticillata. That and the antiarrhythmic drug, amiodarone, are reported to cause that.
There's another question. Is chenodeoxycholic acid available in India? And does ursodeoxycholic acid have a role to play in cerebrotendinous xanthomatosis?
Can be used. I did read an advisory some time back that because of the fact that they had a porcine origin, the government of India had banned the drug. We can check now again. But now there are people who help us even get these drugs from outside. It's just the cost which has to be considered, and the time when we are starting the use of the drug also.
I have one question. Both of you could answer. How many children born with IEM in India every year? A rough estimate could be there.
We'll come to know once that ICMR registry is somewhere down.
Yeah.
See, IEMs are so vast. They are so vast. We have dysmorphic syndromes which have a metabolic basis. So it's, are we just talking about the small molecule? Are we talking about the lysosomal? I think that would help us better.
So since there are no more questions remaining to be answered, so thank you, Dr. Prasanna and ORDI, and over to Dr. Ann or Dr. Prasanna.
Thank you very much to everybody. This is our next session. So we've got Dr. Kavita Srivastava, who's known to all of us, and Dr. Archana Desukar from Sheffield Children's, and Dr. Rajesh Ramachandran from Canada. Thank you so much to our speakers and our moderators for an excellent overview of things, especially to our genetic colleagues. It might seem obvious to you, but it's not so obvious to your child neurology colleagues. So thank you for sharing knowledge with us.
Thank you, Anne.
Thank you, Dr. Raju and Dr. Dalal.
Thank you so much. Thank you for a wonderful session.
Thank you.